Hello, everyone. Welcome to the webinar series on Global Health Insights from Jindal School of Public Health and Human Development. This is a first webinar. It's titled as Universal Health Coverage in a Fractured World, Equity, Access and Power. We plan to host a series of webinars hosting academics, policymakers, and global health advocates and activists. My name is Abdul Kalam Azad. I'm an assistant professor and a program director for the MSc Global Health and Human Development Program. In this school, we offer three programs. One is MPH, then we have a doctoral program in public health and human development. We also have this fully online MSc in global health and human development. In our inaugural cohort, we have students from 12 countries from across the world. In our program, with our students, we explore topics like universal health coverage, not merely as policy targets, but also looking at the political and ethical aspects of it and how power, markets, and social hierarchies shape this kind of areas. Today, I'm delighted to be joined by an outstanding panel. We have Professor Stephen P. Marks, we have Professor Rama Baru, Professor Indranil Mukhopadhyay. Each of them actually brings a distinct but a very complementary kind of a perspective on universal health coverage. Before we begin, I would like to request our participants to share their questions using chat box. I already got many questions from our participants when they registered. We will try to include your questions during the discussion segment. With that, let me invite our first speaker, Professor Stephen P. Marks. Professor Marks is our founding dean. He's also Professor Emeritus at Harvard University. He has taught at several universities, including Columbia, Princeton, before serving as tenured professor at Harvard University from 1999 to 2002. At Harvard, he actually led the FXB Center for Health and Human Rights as a director for a long time. So I invite him to reflect on universal health coverage through the lens of human rights, solidarity and equity, particularly in the light of current global challenges. So, Steve, the floor is yours. Welcome.
Thank you. Thank you very much, Abdul. And it's a great honor for me to speak to this audience on this topic because we are going to try to have a very concentrated program. Let me shift directly to some slides that I'd like to share with you. And then I will take this forward here, share. And all right, put this slideshow, play from the start. Here we are. I hope everybody can see this.
Yes, yes, please go ahead.
Very good. So try to keep in mind that we are taking seriously these concepts of equity, access, and power. And we are utilizing a concept that is fundamental to public health in general and to global health and global health from the perspective of human development, which is that of our school. What I would like to do is to draw your attention to the fact that we are still celebrating what started 3 days ago, the Universal Health Coverage Day. I want to share a distinction between the public health and the human rights perspectives on UHC. I want to briefly mention the models of health systems and suggest that the real challenge before us is which one, if any, is there a silver bullet that will take us to universal health coverage if we agree that it's a worthwhile objective. And we live in a complex world today where new challenges arise, and I want to address that in the context of the drastic reduction of development assistance. So my starting point is to draw your attention to the fact that I've got a little bit of a problem here because I want to, I want to view Um, Abdul, I want to avoid the gallery because that blocks the slides that I can't read. Um, how can I do this?
But we can see your slide.
Okay, I can see the slides. So here's my first point. On 12th of December, the World Health Organization has drawn attention, as it has for quite a few years now, to the celebration of Universal Health Coverage Day. And for that occasion, I think it's worthwhile briefly quoting the officer in charge of Southeast Asia for the World Health Organization, who said that universal health coverage represents a transformative principle in public health and embodies a profound expression of fairness in health policy. It's an occasion to reaffirm our collective commitment to ensure that everyone, everywhere, can access the essential health services they need without facing financial hardships. Now, this stems from a effort in 1978 in Alma-Ata, where the Declaration of Alma-Ata affirmed primary health care as a global commitment of all countries. And this was a milestone that launched what became the formal recognition of sustainable health system for universal health coverage and related sustainable development goals. The focus on UHC and on SDGs came, of course, later, but the starting point is the Alma-Ata Declaration. The theme for Universal Health Coverage Day this year is unaffordable health costs. We're sick of it. And I think this I would like you to think about for a while to say that is this an appropriate terminology to utilize? We're not talking now about what are the policy options, what are the components of health systems that will work better, what are the ways of managing this, what are the financing structures. No, this is expressing true frustration because for so much of the population of the world, access to health is prevented as a result of lack of adequate financial resources. And we're sick of that. And that's, I think, something that reflects that there's good reason in this case, since we've been talking about this since 1978, to say, my God, we're even going backwards now. And we do not have affordable health care for everybody. And it's a good reason to be sick of it. Financial protection, according to the voice of this UHC day, is not optional, but constitutes a core pillar of UHC, as well as a prerequisite for sustained social and economic progress. Unaffordable health expenditures are impoverishing communities, exacerbating poor health, and impeding progress towards the full spectrum of the sustainable development goals. Now, of course, in the public health perspective, this is one article by some colleagues of mine on the promise and peril of universal health coverage. It's mainly taking a public health view of the matter, which has been addressed in making the fair choices on the path towards universal health coverage, a major reflection of the World Health Organization in that publication that you can see, endorsed by the General Assembly in its invitation to member states to recognize the links between the promotion of universal health coverage and other foreign policy issues. Social dimensions of globalization, cohesion, stability. As you can see, this is taking a global approach to a public health issue. But what I want to do is to show a human rights perspective. The Constitution of the World Health Organization refers to the right of everybody to the enjoyment of the highest sustainable standard of physical and mental health, which was picked up in the International Covenant on Economic, Social, and Cultural Rights, which was adopted in 1966, and it contains the basic definition, which again is identical to that in the Constitution of the World Health Organization. So that's the core definition. the right of everyone. Now, if we talk about a human right, that means that everyone has that right. And that same document provides some illustrative examples of what goes into it relating to infant mortality and environmental and industrial hygiene and that sort of thing. So back in the early 2000s, the United Nations Commission on Human Rights established the position of Special Rapporteur on the Right to Health. And the first mandate holder, a good friend called Paul Hunt, decided for the first time, how do we address this question of the right to health in a way that's meaningful to build upon Article 12 of the International Covenant on Economic, Social, and Cultural Rights. And way back then, he determined that the right to health is about an effective integrative responsive health system encompassing health care and the underlying determinants of health accessible to all. So there it became part of the definition of the right to health as including universal health coverage. And that was explicitly set out in this 2019 report of the United Nations High Commissioner for Human Rights that mentioned that the contribution that human rights framework can make to the conceptualization and implementation of universal health coverage, directly on the point. Here is what the human rights framework can contribute. And the things that it can contribute refer to the three themes of our panel today. Those themes are equity, access, and power. And if you look at the human rights approach to achieving universal health coverage, each of those issues is directly addressed: equity, access, and power. Given the shortness of time, I'm going to skip ahead as quickly as I can and refer to the fact that consistent with this approach has been the emphasis on affordability, on financial hardships, on the fact that at the time of the Secretary General's report, 2 billion people were living in extreme poverty and they experienced financial hardship due to out-of-pocket expenses. So in the traditional study of universal health coverage, how do you achieve it? There have been essentially these four models, and we don't have time to go into them in great detail, but these are efforts to say that it doesn't matter whether you're a socialist system or a capitalist system, whether you use private healthcare, multi-payer systems, whatever it is, it has to be implemented in such a way that you leave no one behind. And that's where universal health coverage comes from. So we don't have time to get into these different systems: the single payer system, the social health insurance model, the national health insurance model, and the private insurance and out-of-pocket model. So in the United States, there is a mixed system, and I'm going to devote a minute or two to the way in which it's addressed in the United States and the current crisis faced by the high costs of the healthcare system in the United States as a result of these 6 factors. So the bottom line is that most other developing countries control costs by having the government play a stronger role in negotiating healthcare prices, including, of course, pharmaceuticals. In the US, the lack of political support has prevented the government from taking a larger role in controlling costs. In spite of the Affordable Care Act, that has made some progress and so on. But the consequences of the high costs in the United States are that 1/3 of adults have had to skip recommended medical treatment, and the other consequences you can see listed on this slide. So what are we dealing with today in the current crisis? We're dealing with Trump's second presidency, and in one assessment of that, published in The Lancet, the evaluation concluded the first 100 days of the second Trump administration was unprecedented, with the administration taking remarkably aggressive, often questionably legal actions across the health policy. U.S. administration has already undermined resources, financing, and oversight of long-term care, scientific research, and vaccination policy. So clearly, even before this happened, the United States was a great distance and contrasted with all other developed countries from universal health coverage, and the situation has got much worse. But of course, we all know that the United States is a major global funder, especially through the United Nations Development Assistance Program, USAID, and the cuts have been analyzed by the Institute for Health Metrics and Evaluation in this study on financing global health, in which it determined that U.S. development assistance for health has dropped more than $9 billion in 2025, which is a 67% decline. And it has happened also, UK, France, and Germany have also declined, but not on the scale of the US, which is by far the worst. And the underfunding, by one calculation, is going to result in, I think I entered it here, in millions, tens of millions of deaths, and a more conservative estimate is 9.4 million preventable deaths, including 2.5 million children. Now, here's a challenge that I want to conclude with. We are all denouncing the lack of resources through PEPFAR and through USAID and the tremendous positive role that funding of global health has made towards helping other countries achieve universal, or at least make some progress towards universal health coverage. But according to some scholars from the global south, the crisis brought about by US funding cuts is disruptive, but also a chance for transformation. The good news is that despite the gravity of the US cuts, many countries have already begun to respond with promising domestic actions. The US cuts are undeniably challenging, but represent a pivotal moment for low and middle income countries. If we meet with resolve, the crisis can mark the start of a health sovereignty and sustainable practice. So think of that for a while. Yes, by all means, the hundreds of millions of dollars that have been spent from US sources and other development assistance for health provided by other countries is extremely valuable, but countries should be able to focus, adjust their own policies in a way to achieve the objective. So my conclusions are that the USC is the accepted international standard since 1978. It's been closely identified with the realization of the right to health. But over half of the world's population do not have access to essential health services. Therefore, it has failed to reach the objective identified in 1978, especially for marginalized groups. The USA is the only developed country without a firm commitment to UHC. Its policies are not going to, and they don't claim to seek UHC. All other countries, in spite of their shortcomings, do seek that objective of universal health coverage. And the funding cuts by the United States have drastically reduced both access to health care for people in the US, and there are tens of millions of families that now have no access to health insurance as a result of the policies implemented by the Trump administration, but also the development assistance for health that is cut down. So we are left to ponder the starting point for this unaffordable health course. We are sick of it. In other words, universal health coverage is a mobilizing concept that I hope will be of significance to all of you who want to contribute to public health. And I'm sorry, I'm sure I've gone over time, Abdul, and I will now stop showing the slides. Okay.
Thank you, Steve. It's just really wonderful to hear from you. You have actually grounded universal health coverage in a more powerful way in the question of rights, justice, and solidarity. You also reflected on Almata and the current crisis. Actually, this understanding reminds us that USC, universality, these are very much connected to ethical concerns in global health arena. Thank you so much for doing this. I will come back to you in the latter part of the discussion. Now, I would like to invite our second panelist, Professor Rama Baru. Professor Baru has extensively studied the political economy of health system, especially the privatization and commercialization of health services. Professor Baru is one of the full professors with our school. She was again like full professor uh, at the Center for Social Medicine and Community Health at Jawaharlal Nehru University. It's one of the most respectable universities in the country. She has taught MPH and doctoral programs in JNU for nearly 3 decades. She is also an honorary fellow with the Institute of Science Studies, New Delhi, and honorary professor with India Studies Center at Central China Normal University, Wuhan in China. Her research actually focuses on commercialization, the commercial determinants of health, privatization of health services, inequalities in health services, among others. So I'm really happy to invite Professor Rama to reflect on commercialization and privatization of health services under UHC, drawing on her experience in India and China. Professor Rama, floor is yours.
Thank you. Good evening, and thank you for this invitation. It's an honor to follow Professor Marx, who I think actually set the ethical principles that underline the importance of universal health coverage. And I think there's a despair in the statement of the UHC this year. I mean, the call saying that, it is a situation of despair. And I think we need to see how two Asian giants, that is China and India, have actually walked this path towards universal health coverage. But before I do that, and thank you for this opportunity, Professor Azad, because I started kind of looking a little bit into this concept of universal health coverage. As Professor Marx rightly pointed out, I think the Alma Ata document was very, very important and significant because it underlined the principles of human rights. It talked about universality, equity, and comprehensiveness as core values to building health systems in the late 70s. But I think the period between the 80s and nearly the end of the 90s was a period of really rapid commercialization, if not privatization, of health systems. And as Professor Marx said, it wasn't about political ideologies. I think whether it was a country like China, which had a very, very strong, as you know, a communist single party rule for since the late 40s, or the Indian context, which was a democratic polity, the real essence in both these countries. So I keep saying that there was a period of convergence of ideological positions, especially when China decided to move to market reforms and what you call as market socialism. And India actually went in for World Bank loans, and this was the period of liberalization and the structural adjustment program. So I'm just taking these two countries as examples, but if you read this picture globally, you find that there are certain commonalities, and that's what I want to point out. What I actually did because of this webinar is to really read this the context of UHC across the world, and I looked at two very different interpretations of the idea of universal health coverage. The WHO document on universal health coverage really resonates in a sense with the Alma Ata Declaration. They are talking about comprehensive care. They're talking about essential medicines. They're talking about, access to all, and how the state should play a very important role for universal health coverage. But interestingly, if you read the World Bank's interpretation of universal health coverage, they are really only talking about financial protection. And in that, the translation of that into policy becomes insurance coverage. So, there is this, the word coverage is being used very differently by these two perspectives. I think what is very important for us to understand is that commercialization of health services had started in the 80s itself. And this you see both in China and India. In China, they actually commercialized their public hospitals, which meant that you created them as financially autonomized entities that had to earn their revenue So it's not as if they had a for profit, which was very large and very substantial, like the Indian context, but you actually privatize. You didn't privatize, you commercialized these hospitals, which meant that you had to charge for many of the services, including medicines, diagnostic services. Now, the Chinese had, by the late 1990s, introduced several insurance schemes. It was a fragmented insurance scheme. I'm not going to get into the details of it. They had four different insurance schemes between 1998 to 2007, which was a kind of financial risk protection mechanism. The difference between China and India is the Chinese insurance schemes covered both outpatient and inpatient care, and they were uh, sort of related to basically hospitalized care. And outpatient care was at the primary and secondary levels. But in the Indian context, we had public insurance schemes coming in, and of course, you had the Rashtra Swasthya Bima Yojana, and later on the Ayushman Bharat. But I think the important thing about the Indian model is that we had fragmented public insurance schemes covering roughly about 50% of the population, 40% with the those below the poverty line, which was a targeted scheme. So, what we are actually seeing in the name of universal health coverage, what we are doing is targeted. The Chinese public insurance scheme covered 95% of their population. So, this is the contrast that you see between the two countries. But even in the Chinese case, they had a lot of variation across their schemes in terms of height, the scope, and the breadth. So, when it comes to what will be covered, what will be excluded, all these issues became very, very critical. So, one point I want to make is that these were all demand side financing mechanisms in a largely commercialized health services systems in both countries. So what you found is that this kind of a correct so-called course correction, because inequities became an important issue. There was rising out-of-pocket expenditure, there was catastrophic expenditure, and interestingly, in both China and India, the out-of-pocket expenditure was actually the a very large percentage of it was on medicines and also on diagnostics and consultations. So, in order to plug this, what I would call a leaking vessel in the health system, this idea that you would have these insurance schemes which will be act as a safety net or a protective kind of a space was created, and it very much aligned with the World Bank idea of universal health coverage. Now, I think as Professor Marx also spoke, this led to a lot of discontent in the global as well as at the national level. There were movements, and there were also people within these global institutions who were saying that this is actually not yielding the results we need. And I think the COVID-19 pandemic kind of alerted us even more for the need for the state to come back into the and play a central role. And therefore you started having people making this conceptual distinction between universal health coverage, which was largely focused on insurance in the way it was practiced, and universal health care. So the universal health care was much more closely aligned to the idea of alma mater. And I think what we really, the lessons we have today is that we have tried to tweak the demand side through this universal health coverage, but we have not addressed the deep inequities that commercialization has produced, because the way the public institutions have started, have kind of, been transformed, largely due to market ideas being brought into the public sector through public private partnerships, through contracting out of services, casualization of workforce, has actually denuded the public sector. Then, in the Indian context, we have a very aggressive private sector, and even the Ayushman Bharat is itself a public private partnership in terms of the demand financing and the supply side being a PPP, which means both the public and the private. are providing the required services. So, in all of this, we see many, many distortions appearing. And we are also seeing exclusions. For example, many private hospitals today say we will not treat patients who are covered by these public insurance scheme, whether it is for the central government employees, whether it is for your defense forces, or it is for the Ayushman Bharat, which is largely targeted to the poor. They are saying we won't pay because the government is not able to reimburse. This brings me to the last point, and please tell me if I am running out of time. The point is that actually the Chinese experience taught us that insurance schemes become a liability for the state exchequer. In fact, the Chinese, because for high communicable disease treatment, an aging population, even for reproductive and child health, as well as infectious diseases, these become the four very important pillars where they see that the costs incurred through the insurance scheme reimbursements is not sustainable. So they did a course correction in 2009 where they started investing in primary and secondary care again. So the insurance schemes were going on as they were, but they were also strengthening their primary and secondary, and what they called and described from some of the interviews we've done in China as gatekeepers for cost containment, so that you could handle many of the issues, the gravity of these issues at that level, and then you would reduce hospitalization costs, which would mean that these insurance schemes would not become a liability. We, on the other hand, are, like you say, between the devil and the deep sea. So we are saying Ayushman Bharat is going to bring greater equity, but in fact, we are not supporting and strengthening our primary and secondary level care to the order that it needs to be done. So, and if you look at public investments, they have not increased to the order that's required to actually strengthen primary and secondary care public services. So I think I'll stop here and we can take questions. I hope I haven't overshot the time. And thank you very much for this opportunity to share some of my views.
Thank you so much. It's really interesting to know that how this you said that these two Asian giants, they are working with universal health coverage, and how the insurance is playing out, especially in this case, is really interesting. We have questions on Ayushman Bharat. I will come back with those questions. Also, that question connects with Professor Marx's presentation. But now we will move to our final panelist, Professor Indranil Mukhopadhyay. As I mentioned, he's an health economist and he has been working on health financing and governance, especially in health financing fragmentation. Professor Indranil is a professor with School of Government and Public Policy at our university. He previously worked with Public Health Foundation of India as research scientist. He was also a postdoctoral scientist with Wellcome Trust, and now he is leading this project, Health Financing, Fragmentation and Universal Health Coverage in Brazil, India, Mexico, and Colombia. He is the PI for India country. Professor Indranil also edits Jindal Journal of Public Policy. So I invite him to actually share his experience from his ongoing project. Indranil,
Right.
please go ahead with your presentation.
Thank you, Abdul. And so it's such a privilege and also a very arduous task to follow Professor Baru and Professor Marx. And many of the points they have touched upon would probably try to supplement with some of the evidence that we are trying to generate from this particular research study we are doing. And I may not be uh, so this is a study supported by National Institute of Health and Care Research, UK, and it's on health financing fragmentation and universal health coverage, and we are doing this in four countries, three in Latin America: Brazil, Colombia, Mexico, and India. And if we have partners across the continent. In UK, we have Imperial College London and University of York, and then in each country we have partners, and JGU is the India partner. Now, if we the overall understanding or idea behind this initiative is to improve our understanding of the kind of fragmentation that is there present in low middle income countries, and also to inform what kind of models, what kind of drivers can help countries achieve something like an universal health care or coverage. And like Professor Baru has also mentioned, there is a particular understanding of universal health coverage that essentially brings or narrows down to the aspect of universalization to coverage of insurance schemes. And if we look at, say, the mainstream definition of fragmentation also, and particularly financing, it draws from that kind of understanding that fragmentation is defined by plurality of providers, but also insurers, and fragmentation in choices, and it has implications on quality, access, and equity. But we are, at least in India, we are trying to critically look at this whole definition of, because it also points towards certain solutions to undo or address fragmentation, which is again through financial protection. And our evidence uh, in India is to challenge that kind of understanding. And so, the way India program of this particular grant is structured, we are trying to essentially create a more or create an evidence for various drivers of fragmentation. We are trying to understand subnational issues related to fragmentation. So, and also at the same time, we are trying to evaluate some of the existing mechanisms, tools that are being popularized and being portrayed as major vehicles to address fragmentation. For instance, Professor Baru has alluded to the government funded insurance schemes, and in India these schemes are being seen as major solution to the challenge of fragmentation and lack financial protection. We also plan to look at the political economy of fragmentation, trying to understand the drivers, the challenges that financialization is posing to create inequities in access and leading to further fragmentation. How over time there is deepening dependence on financial instruments to invest or fund healthcare. So, what are the implications? We're trying to understand that. The more and the most important element to our work is to strengthen community institutions and build community capacities. And in this, and I'll come to the capacity building and community engaged component in some time, but we are engaging with civil society, we are engaging with researchers, but also we are trying to engage with grassroots workers to bring in greater accountability, because one critical understanding is through better accountability mechanism of both public systems and private sector, we can address the some of the issues of access and hence fragmentation in access. Uh, I'm not going to get into the detail of it, but one of uh, I'll try to add some. So, in our work, we are trying to understand in two Indian states, West Bengal and Haryana, we are trying to understand current issues and challenges with access and also the situation in terms of financial protection, and we are trying to find out if some of these government funded insurance schemes or social health insurance schemes, what have been their effectiveness in improving access and ensuring financial protection. And our initial findings suggest that there remains multiple insurance schemes that people have access to, but even if people are covered, they are not protected. So, and financial hardship continues to remain a major challenge. We also have got some deeper understanding on various layers of unmet health needs. Unmet health needs starting from inappropriate care that people are forced to undertake because of lack of access to good quality care. From that, inadequate care provided within the public system, and then financial hardship faced when people access care in institutions. So, unmet need and its drivers have become a major one key issue that is emerging from our work. We are also trying to understand care pathways and whether to what extent continuity or discontinuity of care remains among people. We are trying to also complement this work with trying to understand various challenges and bottlenecks in delivering and expanding some of the social health protection initiatives. For in India, there is a scheme called Employee State Insurance Scheme, which has so far remained confined to formal sector workers of certain wage range. And there is a greater call to include informal workers, include workers with certain higher levels of income, so that the most comprehensive forms of coverage and care can be provided. And this social health protection scheme not only provides inpatient care but also extensively covers chronic outpatient care, provides care for compensate people for wage losses, disabilities, deaths, and so on and so forth. So instead of depending heavily on tertiary care focused insurance schemes, we have within the country alternatives of better comprehensive care provisioning. Now, the other crucial component, and I'm skipping some of the other elements of the study, but what I want to draw your attention to is our work in terms of capacity building, particularly capacity building of grassroots workers and community leaders. And this has been a very enriching experience for us. We are trying to, from various parts of the country, we have been able to identify fellows from Bihar, Jharkhand, Odisha, Chhattisgarh, Madhya Pradesh, and UP, and who are already engaged in community-based work in health or other social sector, but empowering them with skills of budget analysis and budget tracking, and also learning from their experience in grassroots level work and community work. And it has been a very enriching experience where people in a journey of co-production of knowledge and understanding, we have it has been a very fascinating, interesting knowledge experience for us, and we see that there is a deep-rooted quest for bringing in greater accountability within the public system and budget advocacy and budget analysis can become a powerful tool in ensuring better access for the people and through better accountability mechanism. And this is an ongoing study, and we are hoping to bring in more critical insights into what is happening within the country, and also compare our findings across some of the better performing Latin American states. And before, if I have another few seconds, Abdul, I'd like to point out that
Please
that's
go
one
ahead.
of the major findings from our work is in Latin American health system, the quality of and availability of information and data kind of system that exists, and transparency is something that we should learn a lot from. In many of these countries are able to produce brilliant outputs using system data, whereas we need to continuously depend on primary surveys. And also the challenges of doing primary work is enormous when we are looking for, say, trying to understand what kind of services are available in public facilities through one critical component of our work, particularly primary care work. We are struggling a lot to get, say, permissions, and then also even speaking to government officials to understand supply side challenges, bottlenecks. So overall, one key insight that we got is one other key insight is that we need better data system to even have a better quality health care. So it's been a fascinating journey so far, and we hope to share, disseminate, and co-create greater understanding of drivers of fragmentation in Indian context, and compare our experience with other countries. Thank you.
Thank you so much, Professor Indranil. I think, uh, yeah, you're back.
I just didn't realize that I didn't switch off my video. My apologies. I'm sorry.
No, 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 no. It's fine. Yeah. So this is really interesting work you were doing. Not only in terms of understanding the health financing fragmentation, but some of the really interesting things like health rights fellowship and looking at the data is really fascinating. And we actually got few questions on what are the examples from India where USC is working in a better way. So you already covered some of those. Thank you so much for this. I will go through some of these questions. Now I have two sets of questions. One I received while uh, registering participants mentioned those questions. Now I also find questions online. I will start with the question that was addressed to Professor Marx. This question is very interesting. The participant says that my question is to Professor Marx. You mentioned that LMICs may find opportunities in the current crisis triggering by Trump administration. In the Indian context, do you think this movement could catalyze greater public investment in health, especially to correct entrenched inequalities and public health justice for historically underserved population? Steve, if you would like to reflect on this. Please unmute yourself.
Of course, the other two panelists are much better qualified than I am to discuss the intricacies of the Indian system. But the one point that I would like to make is that I have observed that international bodies that are scrutinizing comparative approaches to achieving universal health coverage have not hesitated to denounce the low level of investment by India in health. And that's, of course, relevant to that. I don't have the data to show exactly where it's falling short on universal health coverage. Of course, the policy the various programs that Professor Ramabaru mentioned go into greater depth on what works and what doesn't, what's moving towards greater coverage and greater care. And her distinction between coverage and care, I think, is extremely important. But The only point that I can retain from previous discussions of UHC in the Indian system is that those who have observed, whether it's the World Health Organization or the Special Rapporteur on the Right to Health, whatever it is, have not hesitated to point out the very low level of funding on health, the health system in the Indian context, in spite of the fact of these some extremely well-conceived programs, but difficult to implement. So that's just a starting point, is the prioritization of health. Part of demonstrating a prioritization of health coverage is the national budget. And I don't recall the exact statistics. I'm sure Rama knows them, but the percentage of GNP spent on health in India is relatively low.
Professor Rama, Professor Indranil, would you like to reflect on this? Because this is like one of the core issue in this area. If we talk about India, how do we realign?
Yeah, I think Indranil, you should come in about the
Invest.
expenditure, because the center state, you have to.
Right. So, thanks, Professor Babu and Professor Mark. So, basically, if you look at, if we compare India with, say, countries, say our neighboring countries, for instance, Sri Lanka or, say, Thailand or Indonesia, they spend, so Thailand and Indonesia spend 10 times more compared to India. Sri Lanka spends 3 times more. Bhutan spends 3 times more. China, other BRICS countries, Brazil, China, Russia. Russia we leave out because its per capita income is way higher compared to India. Even South Africa spends 15 times more. And majority, so within that low spending, majority comes from provincial governments. And what we have seen during the COVID or post-COVID, that state governments of the provinces have actually gradually steadied their investment on health. They're increasing their spending on health. But the union government post-COVID has made major corrections in and cutting back health budget. So not only we are starting from a very low level, but union government initiatives have been continuously lacking and there are cutbacks. So our data system also is quite challenging. So our out-of-pocket number shows that it's declining, whereas there is plenty of evidence and other surveys suggest that our out of pocket should also be increasing, even some of the other government sources. So, yeah, I think there is a consensus on increased public investments, but there is lack of intent and lack of actual materialization of that so far as the union government is concerned. And states remains, there are challenges vis-a-vis states in terms of how much they can mobilize for health. So,
Yeah, thank you. I have few more questions on India, then I will move to other part of the world. So one question is relevant on this context is India is huge in terms of its population. As as a country, as a state, how feasible is it to provide universal healthcare in a country like India with mass population? There's a question from one of our participants. Again, maybe Indranila, you can go ahead. Or yeah, Rama.
No, I think, you see, whether it's China or India, we have very large populations.
Yeah.
But China certainly does better than us. They had a better human development base prior to the late 1970s. But then you could see that when they commercialized, inequities increased. So that is one. And secondly, this interprovincial or interstate variations in a large country, which is like a subcontinent, is bound to be. So you do find, for example, the variation between some of the northern states and the southern states. and you find the robustness of health service system, the uptake of whatever investments are made and utilizing that money in a much better way. So linked to this whole financing issue is also governance issues. It is also about the histories of many of these. So even in China, you find the same problem. The east and the southern part do much better. The north and the western part, which sort of borders on to Tibet and other parts, you find that there are inequities in even the working of insurance scheme, even in the kind of spending they do on public health infrastructure. So I think and I think that's where Indranil's study is very important. If you look at averages for the nation, but if you don't account for interprovincial or interstate variations, and that's the point he was making, that you need to do a lot of primary work in both China and India, actually, in terms of available data to do some of this analysis.
Abdul, if I may just quickly supplement from
Yes,
one of
please.
the findings from our study. Uh, so it's very clear that though some of these pro-poor insurance schemes, the coverage among the poorer section is slightly better compared to the richer, because by definition that is the case. When it comes to utilization, the poor, marginalized, vulnerable sections use the public sector disproportionately more than the private sector, and compared to the richer counterparts. So, and the benefit of the insurance scheme goes to the non-poor more. Not that everyone is rich, but non-poor. So essentially, you are paying out of public money to fund private investment, and also there is ineffectiveness in financial protection. So within interstate variation and within a state, across vulnerable groups, there remains huge inequity, and poor people dependence on poor people on public system is actually increasing. And if you look at some of the successful initiatives, say, for instance, the National Health Mission, you will see that which provides a limited package of maternal and child health. The public sector dependence on public sector is very high among the poor. So if you deliver people depend on public system. So we need to actually strengthen public system to be able to cater to the needs of the poor.
Thank you. We have a question, but I will keep it for the last part of the discussion. Now, I would like to draw your attention to Africa. So, one of the participants asked, how can universal health coverage be improved better in some of the countries in Africa where health system is still weak and fragmented? So, Noma, yes, please.
I'm very glad this question has come up, because I think Africa represents enormous diversity, both politically and in terms of health service system. When the structural adjustment program came, there were countries who were part of the structural adjustment program that privatized their health services overnight. And in fact, there is this very interesting work done by Priya Nanda for Zambia, where it shows you, see, we commercialized, and there's a difference. Commercialization, you put in some market principles here, you try to change the character of the public services. But in countries like Zambia, they just handed over their health services to the private sector. And they saw the kind of inequities it kind of produced. But at the same time, there is so much variation. If you look at Nigeria, Liberia, it's a different story. But if you look at the countries like Zambia, and very importantly, Sub-Saharan Africa and Rwanda, where there have been conflicts. So you had a weak health system to begin with, which has been further ravaged by conflicts. Ghana is an interesting example. I mean, they also were part of the British colonial legacy, and they have, I think, done some interesting innovations in universal health coverage because they did have historically had built a strong public health service system. So I think when we speak about Africa, we really see a tremendous variations. We also see a humanitarian crisis in those countries which are conflict ridden, where there's been genocide, and health service systems, like all other systems, have completely been, razed to the ground in many cases. So I think uh, it's really a country which is a continent which is worth exploring and working. And I hope students from this course who are from Africa will bring
Yeah.
us more information and knowledge.
Professor Indranil, please go ahead, but to be
Professor
very
Marx,
pointed. Yes.
sorry if you might also have to add something on this. But one additional point I wanted to make about Africa is about its about the solidarity that we see emerging, particularly during the pandemic, the way African countries came together and they advocated for a more progressive mechanism for distribution of vaccine, the PAN fund and other, and also the failure of the global dominant global institutions in being able to respond effectively to their needs and demands. So Africa as a continent with its diversity is also able to, and at least there is some positive intent to come together and raise their voice collectively. We have seen several instances in the last 10 years or so where there is an emerging there is a lot of hope in that, in the global geopolitics and health, the emerging consensus within Africa. Maybe I'm too optimistic, but yeah.
Yeah, no, I also want to conclude the session with a little bit of optimism, since you talk about what has happened in global South, especially in Africa. But we have questions, and we have many questions. I'm sorry that I wouldn't be able to take this really interesting questions, but I want to bring this up for all of your reflection, especially this part of the world, India and China, in the changing geopolitical situation. Steve mentioned how the US aid getting dismantled, US withdrawing from WHO. Now we see a change here. China is committing to invest 500 million US dollar in next 5 years. That should help in increase the universal health coverage in some countries. India, on the other hand, is actively pushing for traditional medicine, evidence-based traditional medicine, and arguing that it should help increase universal health coverage. With this optimism, how do you see that panning out in next couple of years? Yes, Rama, please go ahead.
China is the single largest donor to health in Africa in the last 3 decades. They have actually put in more health aid, and it's an area which has not been adequately researched. And I think it's a very interesting area to look at. They have actually financed, and they've just not financed, they've built health systems. They have trained human resources. Chinese doctors have come to work in some of these, especially Tanzania and East Africa. They have also transplanted traditional Chinese medicine into many of the African health systems. So, I think the point you're making is they always have wanted to play the role of a global health leader. And in fact, all the name calling of the Chinese after the COVID-19 pandemic, uh, they have, they want to give money to WHO, they want to um, influence policy. And so, all this is soft power, right? So they've
Yeah.
used the soft power diplomacy to up their game. But the point I want to make is that they have worked very systematically, and many of us don't even know the depth with which The Chinese have worked in the African subcontinent, and it's quite I mean continent, sorry, not subcontinent, and it's quite telling. Health aid by the Chinese.
Yeah. So if I
Yes,
may just add one sentence, the challenge still remains that self-reliance by countries and developing their own system, having the capacity to manage the distribution of resources, training human resources to address health challenges and achieve universal health care is an ideal. Is it an illusion to think that we can achieve that ideal? And will we then be dependent upon the contributions to be made by development assistance for health coming from China or wherever it is able to come from at the scale that will make a difference? It's a real challenge because we would like for countries not to be dependent upon the
yeah,
global north or on China pursuing its soft power to achieve its geopolitical objectives. On the other hand, can those resources be found at the local level? After all, there is also some good intentions in some of the earlier programs. We disagree very much with structural adjustment programs and so on. But the World Bank wanted the countries to have functioning systems. They simply chose their way of going about it that produced probably more harm than good. But the point was that however you're going about it, you're trying to get countries to become self-reliant. And how can they become self-reliant? You can't just cut funds and find as a result they're going to blossom and be able to address their health needs. On the other hand, you don't want to pursue their total dependence on China or other countries to meet their health needs. It's an enormous challenge that I think probably is I'm now speculating wildly, but I'm doing it to the audience we have here. The future leaders in global health governance will need to address this issue. Those people participating from Africa need to find ways by which Africans can take charge, take responsibility, do the job themselves, and cease to be dependent on others to do it. But on the other hand, resources need to be accessible. So it's a massive dilemma facing the future of global health.
thank you, Steve. I wanted to request all of you to say your final words, uh, but in a really, really short and concise way, not more than 1 minute. Let us start with Indranilda.
Abdul, I think I'll rather give the half of minutes to both. Yeah.
Okay, Professor Rama.
I think the real challenge is how are we going to reconcile commercial interests and public health goals? And I think this is a huge challenge, which I think I'll leave it at that. But like Michael Sandel said, what money cannot buy. But the fact is, money is very much there, and we'll have to
Yeah,
reckon with it.
yeah. Steve, final words.
My final word on this is that one of the things that we haven't addressed so far is how do we translate the human rights approach to achieving UHC? And what it involves is the type of accountability mechanisms that allow people, including people of modest resources, to be able to hold the government accountable. If they are not achieving all of the primary healthcare and secondary healthcare that all the definitions say is part of primary healthcare and part of the right to health, they should have a recourse. They should be able, as the Supreme Court of India has done in interpreting Article 21 of the Constitution, there is a right to health that provides an individual remedy when you are not achieving the right to health. That gap between the ideal of the human right to health for all individuals, to be able to rely on that right to health to bridge the gap between what the government is providing and force the government to provide it, is really a major challenge that lies ahead. And I can assure you that the human rights community is on board. Those people who are working on the right to health internationally, at the local level and so on, do see that as the objective, to be able to hold the government accountable as a human rights matter. And I think India deserves a lot of credit for its interpretation of Article 21 of the Constitution. And Rajasthan for its Rajasthan Health Act. We didn't even talk about that, but another example
Yes.
of the, you wanted positive examples of the future, so there's one.
Thank you so much. It's really fascinating to hear all of you. And the questions I received from our participants is like very fascinating. I'm sorry I couldn't cover like even a quarter of it, but this shows that we have a lot of interest in this area. I also want to share with all of you that one participant has requested that they would like to access the slides you have mentioned. Because of time they couldn't, you couldn't share a lot about those, and they also couldn't capture. So I will request you and I will work with you so that our participants and wider public in general, they have access to these resources. um, I am also very grateful to my colleagues in this school, especially Professor Nandita Bhan. She is the brain behind this idea that we should initiate this webinar series on insights, global health insight. I'm also thankful to my colleagues from our online team, Office of Online and Digital Learning, especially Himanshu and Bijay and other colleagues. They are helping us with the MSc in Global Health and Human Development Program. So I thank all of you. I also invite you to participate in our next webinars. We have plan webinars at least for next 3 months. We will invite you, and I look forward to your participation and enthusiasm similar way in upcoming sessions as well. Thank you and have a very good evening.
Thank you, Abdul.
Best to
Thank you very
everybody.
much. Thank you.
Thank you
Bye
very much.
bye.
Bye.
Bye. Best to
Bye.
everybody.